most notably, some of the changes that have happened in the space involve issues that have to do with vaccine availability at the health facility level, as well as the availability of equipment, and finally the functionality or otherwise of those equipments.
I think at the time that the MOU started, one of the biggest challenges was unavailability of vaccines at the service points, which you must agree is the necessary first step to improving coverage. If there are no vaccines, there is no coverage, regardless of whatever else you do. So I think at the time there were a lot of fundamental problems with the vaccine supply chain. First was the cold storage. As you know, vaccines are typically stored in cold chain all through. At the time in Kano, majority of the facilities didn't have cold chain equipment. Even if they had, they were dysfunctional. So there was no place, even at the state level, at the state store, but also at the local government and health facility levels to be able to store the vaccines appropriately. So that was first problem. Second problem was the distribution as well. It was irregular, it was poorly funded. So states were not taking responsibility for delivering the vaccines to the local government, but also health facilities were expected to come and pick them up from the local governments. In many cases, they typically might not come on time, and these were also because of things around fund availability, but also because they had other activities that they typically would take care of at the facilities, right? So that created a burden on them. I think the third problem that existed as well was visibility. There was no way to know how much stock was at any of these levels, state, local government, health facility, and report it real time so that you could actually respond when there was a stock out, right? So with these challenges in place, there was a need to revamp the complete vaccine supply chain architecture in Kano State. And the first step we took was to solve the cold chain problem, which was really quantify what did Kano need as cold chain across all of the levels, and work with them with investment from the foundations, of course, to procure the right set of cold chain equipment and deploy them successfully at all levels. So a lot of investment was done into solar infrastructure, solar cold chain equipment, solar direct drives, they were called at that time, was the new technology, and those were put in place. So that was a very big and key intervention that helped to change the landscape regarding supply chain. The next was the distribution, as I said. So we instituted a different complete architecture called the direct vaccine deliveries that keep the local government but had the state delivering vaccines directly to the health facilities, and also working innovatively with a private provider, which had never been done at the time, to deliver these vaccines, and then using that as an opportunity to build the state's capacity to deliver. So that created some consistency in terms of the way vaccines were delivered, and also built the third point, which I talked about, which was visibility into the stock. So having a point for delivering vaccines to every facility also enabled us to collect data on where exactly were the stock, what were the stock levels, where were there stock outs that now necessitated an emergency response to address them. So I think with these three interventions in play, there was really a change in the vaccines landscape for the states. I think the last one to call out was now making sure the state was able to take that system on and run it. So that also included instituting a logistics working group, which was where the state government and the partners came together to analyze the information from time to time and then use that to inform decisions and continue to improve the system. So this got us in Kano from a place where we had vaccine stock out rates of above 50% to as little as 4% in the first year, and now has been sustained at 1% or even no stock out at facility level over many years. So these interventions also help to drive the national intervention now to improve supply chain for vaccines across the entire country, and that has yielded, you know, a lot of great impact.
Before, there's no push system at all. We go to the Northwest Zonal stores and pick vaccine for the state, and the zone also come to us and pick. The LGs also go to, before we don't even have the zone, our zone and satellite are not functioning. So LGA comes here to the state council and pick, and also go to the Northwest Zonal Council and pick. That was before. There's no push system at all. But the new system redesigning is now that the national zonal satellite, Northwest Zonal Satellite, pushes vaccine to us on quarterly basis. Then we also pushes vaccine to our local satellite stores and LGS on monthly basis. So every month we now have the stock balance of all the zones. We now look at their maximum. We now top them to maximum, the zones. The zones will also visit LGE and health facilities in that particular LGE. We now look at their stock parameter, stock level. Then they will also conduct physical count and compare the stock balance, the current stock balance, and compare the maximum. So they will now top them to maximum. That was how the system is now going, and that was the new system we are using now.
So initially, even when the direct vaccine delivery started, somewhere around 2014 and 15, partners were even joining the delivery teams to mentor the healthcare workers. They mentor the cold chain officers that were doing the delivery, as well as the healthcare workers at the last mile in those facilities. The logistic working group at the state level at the beginning was top heavy, so it had involvement of all the technical people working in the logistic space at the state level, but no involvement of the people at the zonal level and the local government level. So we now discovered that, okay, that is a big gap, which was now corrected, and the logistic working group now started involving people at the zonal level as well as the LGA level.
Governance is the first thing that has to exist within a system for it to function properly, because that is where the leadership is, that is where everything around coordination is. In this case, when we say leadership, is that for a routine immunization program to work, you need to have quality leadership. And you would find that success, or that ingredient that is leadership, contributes to the success that we see in the better performing states versus the lesser performing ones. And that leadership in this sense is where accountability sits. For the MOU states, through our work, we've been able to, first of all, establish or strengthen the state task force on immunization, which is kind of like the overarching body that does coordination and oversight. Specifically, it's chaired by the deputy governor of each of the states. It's got the commissioner as a member, the executive chairman of the different relevant agencies, as well as local government chairmen and religious and traditional leaders. So that platform serves as a seat of accountability that challenges the agency to be sure that things are going on in accordance with the agreement that was signed. These groups are super important because they ultimately coordinate or manage the program, and there's clear definition of roles, there's clear terms of reference that guide the activities of each of the groups. So before the MOUs, there weren't really any working groups, and what was existent was the polio program, polio eradication initiative, which was mostly at the EOC and manned by the state immunization officer and the incident manager, and a few of the partners that were present. These meetings were not typically structured. They weren't guided by a schedule. There wasn't any real deliberate effort to ensure adequate program management in a sense. The state task forces were also there, but all they did was meet around the time for a polio campaign, and they would really just discuss. So there weren't really any structures in place for routine immunization specifically. It was typically the one-man state immunization officer who, took decisions and executed the different pieces of work. With the MOUs, a number of things came into play. But before I describe that, also looking at the work planning. So it used to be that the work plans were individualized, so all of the different partners, multinationals or local partners implementing routine immunization, we're all implementing independently, and there wasn't really any harmony or coordination in who was doing what. They also were in budgets to define how much the immunization program needed every year. And as such, release was very, very poor, because for you to be able to ask for money, you need to know how much that you're asking for. But we have been able to get the RI work plans to be comprehensive and to be fully costed, and with working groups to execute them across all of the different themes. We've been able to strengthen demand through involvement of traditional leaders. We've been able to get the states to ultimately continue to prioritize immunization, continue to manage their programs using best practices and business standards. There's different levels to the successes that I would like to highlight. First of all, I think it's important to note that each of the 6 states are unique, and there's different levels of success in each of the different states.
In each of the working groups, there's assigned technical supporting partner from SCIDaR supporting that particular working group. We have somebody mentoring our finance team. We have fully established a functional working group, and this has eased the activities of routine immunization in the states. The only structure in the states that is fully functional is routine immunization.
They only report the weaknesses of our staff. They don't report the technical challenges during the implementation of an exercise.
Now, with the establishment of this structure, we've been reviewing our performances on a weekly basis to look at the session conduct, session plan, session conduct.
Well, to my knowledge, what has been improved is the accountability. And then fishing people who are passionate and ready to do the work was another issue. That took us, nearly a year or 7 months before we got that done.
The NNRISP has been able to steer the states to achieve a lot of their MOU milestones.
Our cold chain activity, cold chain supply and distribution has improved markedly. The supportive supervision, financial management and tracking of financial system, and that has improved greatly with the coming of the MOU in place. After about 4 years, the MOU partners reviewed the activity and analyzed that, look, we need to have more partners coming in, and then we also need to expand to PHC MOU. Bill and Melinda Gates sent an organization from America. I remember last year, they came to learn our financial management system. They want to use it in the other world.
So we have that success of having stronger systems that are resilient and that have this well-oiled engine that continue to the operations are really smooth. Being able to get governments to pay monies for immunization programming, which had never happened before, through consistently demonstrating results and following up, supporting the states to advocate for fund releases. We have been able to get the RI work plans to be comprehensive and to be fully costed, and with working groups to execute them across all of the different themes. We've been able to strengthen demand through involvement of traditional leaders. We've been able to get the states to ultimately continue to prioritize immunization, continue to manage their programs using best practices and business standards. We've been able to also improve coverage to varying extents in different states. We also provide a lot of data analytics support, and of course that's linked with capacity building, as well as general day-to-day support. Really, most times the state provides different or sends us different TA requests that we try to help them fulfill and ultimately help shape the direction of the program altogether.
One of the success of this system is the eradication of the stock out. We hardly get stock out now because every month our people build that facility and supply vaccine there.
because of the support that we provide in these states, it has been expanded now to primary health care. And we've also seen within Nigeria other states emulating, or other donors rather, emulating the MOU approach, and of course understanding that you would need that kind of management support to get it done. More importantly, at national, a lot of the interventions that were innovated and trialed in the MOU states are starting to become national strategy. So for example, the name-based community engagement strategy was an offshoot of the NNRISP project and ultimately became a nationally adopted strategy that is now implemented in other northern states. Of course, the routine immunization financial management system that we designed and rolled out in the MOU states have also taken a lot of, or have also spurred a lot of interest, and a lot of people now believe that, you know, it is possible to put donor money in government coffers, and there is a financial management system that can guarantee that those funds will be judiciously used, and that's also demonstrated by you know, having other donors like UNICEF joining the MOUs because they trust in this financial management system, or, you know, donors like Gavi thinking about replicating those kinds of systems in their own supported states as well. And I know that at national level conversations are also going on.
I think some of the challenges that have persisted over these years, you know, include the reporting of you know, issues that usually arise at the facility level, for example, breakdown of cold chain equipment, or some weaknesses in the preventive and corrective maintenance. So there are still issues around that, both in the reporting and in the actual conduct of the preventive and corrective maintenance of cold chain equipment. So that is something that still you know, exists.
The variations that we find in coverage could be attributed to things around demand side challenges, which is something that we've continued to work on with different levels of success in different states due to a myriad of factors. I think that the biggest challenge, and that is something that we acknowledge and across the board is evident, is that the technical support that we've provided have been able to strengthen systems and get the routine immunization programs to be very mature and very advanced, but haven't quite translated to increases in coverage to the extent that we all desire. We are making progress for sure and definitely, but the progress is not as fast as we would all like. And I think that part of that is understanding that there is a limit to what you can do if you strengthen the supply side without strengthening the demand side with equal or even more measure, because at the end of the day there are a lot of social norms and different socio-cultural factors, especially in northern Nigeria, that influence immunization. But across the globe, you know, vaccine hesitancy is a thing, and it's something that we continue to grapple with as implementers in the field and also as thought leaders in the space. I think that another challenge, of course, is because we're working with government systems and we know all of the many issues that exist with government systems and with the civil service, it's sometimes difficult to get things done and things done as fast enough within a fast-paced context like routine immunization programming, where everything and every day matters in terms of planning and in terms of the number of children we can save. Putting this on government systems that are inherently, would I say, weak, obviously comes with shortcomings, because it means that a lot of times you have to wait and you have to, you know, push through to get things done. And of course, that is very rigorous work and very daunting as well. So I think that there is always some level of, would I say, it's challenging to work in that context. basically. But then, of course, with time and with continued influence and building relationships, it gets easier, but it's something that we continue to grapple with within the program. Another thing that I would say, which, you know, it depends on the lens that you look at this from, is the capacity retention, right? And for some, and I would say on one side that can be a success, or that is a success, in that when you capacitate a government staff and they're now able to fully do their function, within the next year or so, you find that they have moved out of the government system and into the private sector or into the NGO world. And that means that we're able to build capacity to a point that the person, you know, has better opportunities and all of that, and that's an individual success. But for the system, it means that you have lost some capacity that you now have to fill again.